Very good morning, everyone. This is Dr. SAICHARAN, Senior Lecturer, Department of Conservative Dentistry and Endodontics. Today, we are going to discuss about the topic electronic apex locator. So, we'll be discussing the definitions, the correct name for the device, the anatomy of apical foramen, the limitations of traditional working length technique, the emergence of electronic apex locators, the general history, the parts of electronic apex locator, how to use it, and what are the precautions to be taken, what to be avoided to obtain a correct reading, and the advanced models of electronic apex locators and the significance of them. So coming to the definition, an electronic apex locator is an electronic device that is used in the field of endodontics to determine the position of the apical foramen and its location, and thus determine the length of the root canal space. So this step is very important, because if you fail to determine the correct position of the apical foramen, where your BMP should start and end, the cleaning and shaping should start and end. If you are going wrong, then you might end up with an over obturation or under obturation, which is not good for your longevity of your root canal treatment. So what's the correct name of this electronic apex locator? It is called as electronic root canal length measurement device, ERCLMD. And in general terms, we call it as electronic apex locator or apex locator as such in our regular day-to-day life. So the anatomy of apical foramen, this is very important, because often we go wrong that what should be the reference point, where should we end our cleaning and shaping. So our cleaning and shaping should actually end at the minor constriction at the B here, the point B here, whereas the A is the major apical foramen. So it may or may not coincide always with the radiographic apex. The radiographic apex is E. So what often happens is that we think that an RCT is good or bad. We determine based on seeing the, excuse me. Yeah. Based on seeing on IOPA, we decide that the obturation is not till the apex, till the radiographic apex. No, it is not right. So our obturation, our cleaning and shaping, and our obturation should end at the minor constriction, which is at the minor apical foramen, which is at B. So how do we be able to localize, specifically find out where is this apical constriction? So there are traditional methods where we use the apex, the radiographs and everything to find out. But the problem with the radiograph is we will be able to only find a radiographic apex, not the anatomic apex, which is also known as the minor apical foramen. So we don't know. So how do we find it? So it is much easier to find out a minor apical foramen using a electronic apex locator. And there are some pros and cons of it that we'll be discussing in the later on slides. Let us see. So in clinical practice, the minor apical foramen is a more consistent anatomical feature that can be regarded as being the narrowest portion of the canal system, and thus preferred landmark for the apical endpoint for root canal treatment. This is what I have told you a little while ago. So our obturation, our cleaning and shaping should always end at the minor apical diameter, not at the radiographic apex. It should be always at the anatomic apex. You can see in the picture, not every time your the end point, the terminating point of your root canal will not be always at the radiographic apex. It can be anywhere in the 1 to 3 mm of your apical third of your root, right? So the anatomy of the apical foramen changes with age, maybe because of supraeruption, deposition of cementum and everything. So it need not be always present at the anatomic, at the radiographic tip. The apical foramen is not always located at the anatomical apex of the tooth. The foramen of the root canal may be located to one side of the anatomical apex, and sometimes it is up to 2 mm short radiographic apex in 50% of the roots. You can appreciate here the picture, picture A, B, and C. At the picture A, you'll be able to appreciate the exit of the root canal at the tip of the root, whereas in B and C, it is towards the lateral side. The limitations of traditional working length assessment. So the radiographic determination of working length has been used for many years, The radiographic apex is defined as the anatomical end of the root as seen on the radiograph, while the apical foramen is the region where the canal leaves the root surface next to the periodontal ligament. When this apical foramen exits to the side of the root or in a buccal or lingual direction, it becomes difficult to be viewed on the radiograph. So the tooth will superimpose the canal exit, so it will not be well appreciated in a radiograph. This is what happens when you are determining the root canal length only with the help of a radiograph. Dense bone and anatomical structures can make the visualization of the root canal files impossible by obscuring the apex. The superimposition of the zygomatic arch has been shown to interfere radiographically with 20% of the maxillary first molar apices and 42% of the second molar apices. So the deposition of secondary dentine and cementum can move the apical constriction further from accepted limits, causing perforation errors. So the idea of saying, discussing all this is that you cannot solely rely on the radiographic component to check the working length of a root canal space. So using an apex locator can predictably give a better results, but it's always not accurate, maybe not 100%. But to an acceptable limit, electronic apex locator can help you arrive at a correct assessment of the root canal space. A radiograph provides a two-dimensional image of a three-dimensional structure. That is the major drawback. And it is a technique sensitive in both its exposure and interpretation. Radiation exposure is always avoided in pregnant women, so that's the reason we don't prefer taking radiograph. Rather, we take help of an apex locator to finish off the RCT in pregnant women. So it's also difficult to take radiograph in patients who have gag reflex, patients who are not comfortable, who are specially able children or specially able patients. In such patients, we in certain cases where we use conscious sedation and it's not possible to ship the patient. If you don't have a portable X-ray unit, it becomes very tough to take a radiographic assessment of the working length. So that's the reason an apex locator will be much more helpful in such cases. And it also has the difficulty in taking X-rays in patients who have phobia of radiographic exposure. There are patients who are over concerned. Even though our dental X-rays have very minimal exposure compared to the conventional medical X-ray systems, there are certain patients who are very conscious about taking a lot of X-rays, because every root canal treatment might require a pre-op working length X-ray, a master cone X-ray, a post-observation X-ray. 4 to 5 X-rays are needed. So it becomes little cumbersome for the doctor as well as the patient to accept that we should take more radiographs in the same patient. So in such cases, electronic apex locator will be more handy. The importance of radiograph. The preoperative radiograph is essentially in endodontics to determine the anatomy of the root canal space. Even though we say that radiographic assessment may not be accurate all the times, you cannot completely ditch off the radiograph system, because it helps you to analyze the root canal space. How many canals are there? Is there a curvature? Is there a deep split if it is there in the root canal system, or if there is a calcification, if there is a lesion? So you cannot always avoid a radiograph. Radiograph is always required along, maybe with the help of a apex locator. Our results might be much more predictable. So that's the reason we cannot completely neglect a radiograph. The electronic apex locator, when used with appropriate radiographs, allows for much greater accuracy of working length control. So the emergence of electronic apex locators, an electronic method for root length determination was first investigated by Custer in 1918. Then the idea was revisited by Suzuki in Japan in 1942, and Tsunada in 1962 took this principle and constructed a simple device. Since then, Japan remains the leading country in developing newer and improved models of electronic apex locators. The first generation in 1969, which used the resistance method and alternating current. The second generation, the change in frequency method of measuring, was developed by Inu in 1971 as the Sono Explorer. And the third generation apex locators are similar actually to the second generation ones, except that they use multiple frequencies to determine the distance from the end of the canal. One such is index or apid, which are reported in the literature, which give a combined accuracy of 81% to within plus or minus 0.5 mm of the apical foramen, and root ZX from J. Morito, it will give you an accuracy of astounding 95 to 99%. So one of the best apex locators what are being used from many years by endodontists are root ZX from J. Morito. The fourth generation, an example is Bingo 1020. Tinaz et al. Found that Bingo 1020 to be as accurate as the root ZX in an in vitro study, and then easier for a beginner to use in the pre-flared canals. It is marketed by DENTISTRY system. So this is an apex locator. There are different models. This is one of the models. You can see the readings on the screen, and there will be a wire which will have two components. One will have a lip hook and another one will have a file clip, which will be connected to the file, a K file, and the K file will be introduced into the root canal, which we want to assess the working length. And when the circuit is complete, a very minimal current will flow through these two components, and when the file reaches the apical foramen, the circuit will be complete and the current will be flowing, and the current flow will be recorded as a reading on the screen of the apex locator. And depending upon how much is the distance of the tip of the K file to the apical foramen, the measurement will be shown on the screen as 0.5 mm short or at the apex or beyond the apex. So how to use it in clinical use? First, we have to analyze the root anatomy for curvature and establish an estimated working length from the preoperative radiograph. So we know if it is a central incisor. So on an average, a central incisor's working length will be around 23 to 24 mm. So we'll have that in mind and we'll compare it with an X-ray, and we'll try to extirpate the pulp and everything. And then we take the help of a apex locator to confirm our idea that it should be 23 or 24. So it might be 22.5 or 23.5 or 24.5. So it will be in that range. So you cannot blindly go with an apex locator saying that, okay, the apex locator is showing the reading as 15. So it should be, you should be doubtful that it might not be a correct value. So you have to compare it with a preoperative radiograph. You have to check whether it is, the root is having, the tooth is having short root or longer root. Based on that, you have to compare and come with an average value in your mind, and then compare it with your apex locator to get a much more accurate result. The coronal aspect of the canal should be opened or prepared to provide a straight line access or a glide path to the apical aspect of the root canal. And then the modern apex locator generally functions well, usually in the presence of fluids and irrigants in the root canal. Prior apex locators, if we have excess of irrigating fluids like hypochlorite or saline inside the canal, you might get a wrong reading. But now the apex locators, which are contemporary ones, they usually generally work well. But you should always make sure that the pulp is properly extirpated, and should also maintain that there is not any fluid inside the canal before checking the working length using an apex locator. Once the lip hook and the lip holder are attached, in most cases, a size 15 or 20 file is advanced into the root canal until the blue scale on the apex locator reaches the apex and red triangle. So here you can see the picture. If you see the second picture, when the file is introduced and is almost reaching 0.5 to 2 mm of the radiographic apex, you can see the reading there that it is reaching the apex on the screen. And when you are approximately 0.5 mm, it shows the reading as 3. And when you are at the apex, it shows as red at the apex. So there can be a mild discrepancy of 0.5 to 1 mm. But when you take multiple readings, you might come out with a much more acceptable value of the working length. So when you are at the apex, you will tend to minus subtract 0.5 mm because we don't want to obturate at the apical at the apical constriction. We to make a tuck back, we subtract 0.5 mm from the measurement. So what are the precautions to be taken in order to avoid a false reading? The file of the locator should not be in contact with a metal crown or a fitting. you are doing a RCT or a VRCT through the crown, if you are drilling the access cavity through the crown, you should make sure that your metal crown or a PFM should not be in contact with the file. So you should make sure, otherwise you will get a false reading, premature value you will get. There should not be any fluid in contact, as I told you, but the latest ones will not matter much. Generally, the apex locator should be in the absence of fluid. Some newer models overcome the above mentioned limitations, the latest ones, root, ZX, Index, PropeX from Dentsply, all these things. But we should make sure that the pulp is properly extirpated, and as far as possible, we cannot 100% eliminate the moisture from the canal, but if acceptably, we have to remove the moisture and then check for the working. As much of the pulp tissue as possible should be removed prior to using the locator, and the largest file that will bind up the apex should be used. And what are the precautions? Loose fitting instruments should be avoided, and always, except in unavoidable situation, the reading should be confirmed in collaboration with radiographic findings. This is what we discussed before. And electronic apex locators are ineffective in case of teeth with wide open apex, as obtaining correct reading is almost impossible, because the current might get a premature value. So in open apex cases, you should be very careful. And electronic apex locator should be avoided in patients wearing pacemakers. If you have a pacemaker in the heart, so they say that there will be a interaction between the minor current from the pacemaker as well as your apex locator, and there might be wrong reading. And the latest literature says there is not any interference, the latest ones. But the older literature says it's better to avoid in patients who have pacemakers in the heart. So coming to the conclusion, no individual technique is truly satisfactory in determining the endodontic working length. Cemento-dentinal junction or the apical constriction is a practical and anatomic termination for the preparation and obturation of the root canal, and this cannot be determined radiographically. Modern apex locators can determine this position with accuracies of greater than 90%, but still have some limitations. And the knowledge of apical anatomy, prudent use of radiographs, and the correct use of an apex locator will assist practitioners to achieve predictable results. Thank you. We'll meet another day with another topic. Take care.